George has written in with a problem. He's got a problem of rectal bleeding and he's not really sure what to do about that. He's also a tradesman. He doesn't really like doctors. Fair enough. He doesn't want anyone examining him, particularly, not in a private area. He's not like that kind of thing. He's very particular about this sort of issue. But it's been persistent and he's concerned enough about it, and he's also getting a little bit of pressure from his, number one in his life, get on and get something done. So when we see that hear that sort of story, we want to ask George a few questions. George, how long have you been bleeding for? That's quite important. Is it just 1 or 2 shows of blood, or have you been bleeding now for about a year or so? And we like to know what the blood is like in terms of its description. Is it bright and red? In which case we might be thinking it's coming from a very low point in the bowel, but perhaps hemorrhoids, not necessarily. Or is it a bit darker? Is it darker red blood? In which case it might be coming from a little bit further up in the bowel, and that could raise some concerns about what the underlying pathology, underlying abnormality is. Are there blood clots at times? What's the volume of blood? Is it mixed with mucus? Has he had a change in the bowel pattern? Is he now straining? Where we think about hemorrhoids in relation to straining. Does he have some diarrhoea that he didn't have before? Has he got some abdominal pain? Does he have more bloating now that he didn't have before? Feeling a bit of discomfort on one side or the other of the abdomen? They're all really important questions. And then, of course, we also want to know what his family history is like. What are your parents like, George, and your brother and sister? Do they have any history of bowel problems? For example, without wanting to frighten you, have they had bowel cancer, or have they had a history of polyps, or do they have a history of diverticulosis, or the hemorrhoids run in the family? So we like to know about all those sorts of things. And when we're approaching a problem, we need to be open-minded about what it is we're looking for. At 40-year-olds, the risk of having bowel cancer at the age of 40, if that's the most important thing we're sort of considering, is reasonably low. But it's not impossible. We know that something like 1 in 5 bowel cancers now are being seen between the age of 20 and 54. So there's been a shift toward younger people developing bowel cancer. But what we're thinking about in our mind is really based a lot on his description. And at 40, we would say the risk of something serious is relatively low, but nonetheless, he should be evaluated at that age. And the preference would be to evaluate him by a colonoscopic study. So a full examination of the bowel while he's asleep with a telescope called a colonoscope, which allows us to examine for inflammations of the bowel, allows us to examine for diverticulosis, polyps, which are lumps of tissue that go on the bowel wall and can be the precursors of cancer. And of course, it allows us to examine for cancer. And then from that, we can determine what sort of treatment strategy we're going to offer him. Is it just going to be hemorrhoidal treatment, which might be very conservative, high fibre diet, hemorrhoidal creams, or maybe seeing a surgeon and having some local treatments performed? Or is it going to be a medication that's directed against inflammation? Is it going to be remove the polyp problem fixed, or is it going to be a much more serious discussion with George about cancer we've just found that needs to be evaluated? If George was younger, suppose he was a trade at 25, we're not thinking really here of serious pathologies. We're much more thinking about local bleeding from the anal canal like hemorrhoids. But again, it's very description dependent. What was the blood like? That really does change the thoughts in terms of how we approach this. If someone's older, say in their mid-60s or 70s, we're sort of skewing our thoughts toward some more serious pathology because, unfortunately, age brings more serious pathologies. We're more likely to get bowel cancer as we age. So they're the sort of things to think about. So I'd say, George, man up, muscle up, come and have a chat with your local doctor and be prepared to have an evaluation like a colonoscopy. It's very important.
Is there any, there needs to be a high attention to his habits and so forth? Do you recommend writing it down? Because most people go to the toilet and flush and never look, right?
Yeah.
But once it happens once, he needs to pay attention to these questions.
Yeah. So it would be very helpful if George comes in and says, I saw some blood, don't know what it was like, really, didn't pay any attention to it. We would. That's not particularly helpful. We'd like him to really pay attention to his body, to listen to his body, and to pay attention to the bleeding, that colour, how much, whether there are blood clots, and we mentioned whether there's a change in bowel pattern. Are the bowels looser or harder? Is there new abdominal discomfort? Might not be pain, but just might be like a vague gnawing discomfort, might even wake him a little bit from his sleep. And he might think in his mind he's got an ulcer. In fact, he may have something more significant in his bowel that needs to be checked out.
And then things like diet and so forth that may be causing this, or because hemorrhoids are caused by
training.
What causes hemorrhoids? Is it because it might be trading, it might be straining at work or lifting things. So just a bit about what causes hemorrhoids and how much is diet related and activity, just as a general information, I guess.
So if we were thinking about the diagnosis of hemorrhoids, what we're talking about are big venous structures, big veins. They're like varicose veins, right sitting in the anal canal. And they do tend to run in families to some degree, so there's always genetic factors that influence what we develop as humans. But other factors play a big role. So environmental factors. He's a tradesman. He's probably lifting things, training, bending. He might also, and that's a risk factor. So for ladies who've had pregnancies, all that pelvic congestion and strain during childbirth and through the pregnancy is also a risk factor for hemorrhoids. So the environment in which you're living and existing is very important, and the diet's important too. I don't want to make a generalisation about tradesmen not having great diets because they're often very fit, but if he's skipping meals, not having much cereal, not having complex fibre in his diet, he might tend to be a little bit constipated, or he might be in a situation at work where he can't easily go to the bathroom because there isn't a comfortable bathroom on site. He's sort of holding back and then getting a bit constipated from that, and then straining. So that's a big risk factor for hemorrhoid development.
So how do hemorrhoids produce blood? Like how do they actually...
you've got this venous structure that's right at the anal canal that's very poorly supported by the tissue overlying it, and little blood vessels on that surface structure then tend to bleed. It's a little bit like blowing your nose, I guess. If you're repeatedly blowing your nose, eventually some blood will come. The whole structure gets a bit inflamed, a bit unstable, and that bleeding is quite confronting. People can lose quite a lot of blood occasionally, even require blood transfusions from hemorrhoids. But we don't like to ever make the assumption that bleeding is just a hemorrhoid. And occasionally it's not even that easy to determine it by a rectal exam. So we generally like to have some sort of direct inspection of the anal canal and the rectal region. And in a younger person, someone who's under 25, we might even do a limited colonic examination. That's called a sigmoidoscopy, where we use the same instrument. We're only examining a small part of the bowel. But for older patients, certainly at his age, 40, we want to examine the entire bowel and be really definite and thorough and sure that we've got the diagnosis correct, and then we can offer him the appropriate management strategy.